Welcome to the deep dive. Today, we're cutting a path through the anatomical density of one of the body's most crucial systems.
We certainly are.
We are diving deep into the kidney and the ureter, essentially creating a comprehensive mental map of Chapter 72 of Gray's Anatomy.
It's such an essential map to have because, the kidney is so much more than just a filter. Of course, it manages water, electrolytes, excretes metabolic waste.
Yeah,
But the real power is in its endocrine control.
it's a hormone command center.
Exactly. We're talking about the production of erythropoietin, which signals the bone marrow to create red blood cells.
Right.
Then there's renin, which is absolutely critical for long-term blood pressure regulation, and of course the active form of vitamin D, which coordinates calcium and mineral metabolism throughout the body.
So, without this organ, none of those core survival systems work.
They just don't.
So our mission today is to walk you, the listener, through the gross anatomy, the inner workings, the, dense vascular architecture.
And most importantly, the clinical correlations.
Yes, those surprising spatial relationships that dictate surgical risk and diagnostic imaging. We want you to really visualize this entire system.
Okay, so let's set the stage. Let's start with placement. The kidneys are reddish-brown, bean-shaped organs, and they are retroperitoneal.
What does that mean exactly? For someone just tuning in.
It means they sit behind the protective layer of the peritoneum. So they're nestled snugly against your posterior abdominal wall, one on each side of the vertebral column.
And their vertical position is a classic clinical detail, isn't it? That the right kidney is always a little lower than the left.
Always. And the reason is simple. The massive right lobe of the liver just pushes it down, pushes it caudally.
Okay, so what are the landmarks?
The superior border of the left kidney sits around the T12 level, that's your lowest thoracic vertebra, and extends down to L3 or L4. The right side is typically dropped about one full vertebral segment lower.
So when a clinician is describing pain or looking at imaging, those vertebral landmarks are really key reference points. Now, here's one of those immediate critical insights that I think often gets glossed over. The kidney's true orientation. You might think of it as sitting flat against your back, but it doesn't.
Correct. It's angled. The long axis of the kidney is directed inferolaterally, so down and out, and the transverse axis is directed posteromedially.
And that's fundamental for surgery.
It is. It means the surface facing forward is actually the anterolateral surface, and the surface facing the back is the posteromedial surface.
Wait, so if a surgeon is performing, say, a percutaneous procedure coming in from the back, they aren't hitting a flat posterior face, they're aiming slightly medially.
That's it.
Does that angular position help protect the great vessels or something?
It does. That angular position is key because it changes the relationship with the neighboring muscles and ribs, allowing for safer access. It's all about creating safer angles of approach.
Let's move to the external structure. A typical adult kidney, how big is it?
About 11 centimeters long. It's usually well protected by ribs and fat, but anatomists note that in very thin individuals, you might just be able to palpate the lower pole of the right kidney
How do you do that?
bimanually during a deep breath,
Yeah.
but it's not common.
Okay, and this brings us to the crucial layers surrounding the kidney, the renal fascia.
Yes, it's a fibrous connective tissue sheath that contains all the perirenal fat. Historically, you might hear it discussed as two separate layers.
Gerota's fascia and Zucker-Kendall's fascia.
Right. Gerota's anteriorly and Zucker-Kendall's posteriorly. But the modern view, especially with imaging, treats it as a single, complex, multilaminated structure
Why does that structural nuance even matter?
because it influences how fluid or infection spreads. The renal fascia is fused posteromedially with the deep fascia of the psoas major and quadratus lumborum muscles.
So it contains things.
It's meant to. But clinically, while fluid is usually contained, modern analysis shows that the fascia isn't a perfect barrier. It can occasionally communicate across the midline at the L3 to L5 levels.
So fluid could actually pass from one side to the other.
It's rare, but yes. And this structural understanding, it directly translates to surgical planning. It's fascinating.
So we're talking about the difference between a simple and a radical nephrectomy.
Exactly. A simple nephrectomy is where the kidney is removed inside that fascia. But for a radical nephrectomy, maybe for cancer, the surgeon has to take the entire contents of the perirenal space, including the suprarenal gland and the fascia itself.
That distinction really justifies why we spend so much time on these subtle fascial boundaries.
It does. Now let's find the main entryway, the hilum. This is on the concave medial border, and the hilum opens anteromedially.
Okay, so if you're looking at the kidney from the side, the three main structures passing through have a critical order, from front to back.
Yes.
VAP.
The V, the renal vein, is anterior. The A, the renal artery, is intermediate. And the P, the renal pelvis, is always the most posterior structure.
That VAP mnemonic is just non-negotiable for understanding imaging and surgery.
Absolutely.
Excellent. Now that we know the wrappings and the doorway, let's look at the neighborhood. The organs resting against the kidney's anterior surface, and they're really different on each side.
Wildly different. The right kidney has these heavy-hitting digestive contacts. Superiorly, it touches the right suprarenal gland,
Okay.
and then a vast area below that is related directly to the enormous right lobe of the liver.
Right.
Medially, it makes contact with the descending part of the duodenum, and inferiorly, you have the right colic flexure and small intestine.
The left kidney, though, is a bit more scattered.
It is. Superiorly, the medial half contacts the left suprarenal gland, but the lateral half is cradling the spleen. Immediately below that, a central, roughly quadrilateral area is in direct contact with the pancreas and the splenic vessels.
That sounds like a high-stakes zone.
It is. Then, inferiorly, you have contact with the stomach, superiorly, and an extensive medial area related to the jejunum.
It's a busy, asymmetrical landscape, but thankfully the posterior relations are a bit simpler.
A lot simpler. Remember, the posterior surface is posteromedial, embedded in fat, and thankfully, no peritoneum.
On both sides, superiorly, the kidney relates to the respiratory diaphragm. And crucially, the custodiophragmatic recess of the pleura is right there.
Which is why a kidney infection can sometimes irritate the lungs. And the kidney sits on the medial and lateral arcuate ligaments.
Okay, and as you move down?
As you move inferiorly, you feel the three major muscles running beneath it, from medial to lateral. Psoas major, the large quadratus lumborum, and the aponeurotic tendon of the transversus abdominis.
And what about the nerves and vessels back there?
Right. Running across the back are the subcostal vessels and three key nerves: subcostal, iliohypogastric, and ilioinguinal.
Now let's move inside the fibrous capsule. The architecture of the filtration machinery and the collecting system.
Okay, so we have the outer layer, the cortex, and the inner layer, the medulla.
Right.
The medulla is composed of these conical, striated renal pyramids. Their bases face the outside of the cortex, and their apices converge toward the center of the kidney as renal papillae.
And the cortex isn't just an outer layer, is it?
No, it also sends extensions, called renal columns, down between those pyramids.
This architecture creates the drainage pathway, right? Starting from the center, the renal sinus.
Yes, which is that fat-filled space the hilum leads into. Urine drains from the collecting tubules out through those papillae and into these funnel-shaped minor calyces.
Okay, so papillae to minor calyces.
Then 2 or 3 minor calyces merge to form the larger major calyces. These 2 or 3 major calyces then drain into the main renal pelvis, which narrows down to become the ureter.
There's a surprising detail for visualization here, especially on imaging. The whole system rotates during development.
It does. The calyces that started out laterally in the embryo, they actually rotate to become positioned anteriorly in the adult kidney.
And that rotational anatomy gives the minor calyces that characteristic delicate cupping appearance you see on an image.
Exactly. And if you see hydronephrosis, that swelling or high pressure in the kidney from an obstruction, that beautiful cupping is completely obliterated. It's rounded off. It's an immediate diagnostic marker.
Okay, let's move on to the vascular system. This is where the kidney, it just demands attention.
It really does. The renal arteries are phenomenal. They branch laterally off the aorta and carry about 20% of your entire cardiac output.
That is a massive volume of blood for an organ that's, what, less than 1% of your body weight?
It's incredible. And the 2 renal arteries have very different paths to get there. The right renal artery is noticeably longer.
And it has to snake posterior to the inferior vena cava.
Right, and also posterior to the pancreas and the duodenum. The left renal artery is shorter and just passes behind the left renal vein.
Okay, so once inside, the arterial branching sequence is this famous anatomical hierarchy.
It is. The main artery splits into branches for the 5 segmental arteries. And here's the critical functional point. These are effectively end arteries.
Meaning, if one gets blocked, that's it for that segment of the kidney.
That's it. The corresponding segment loses its blood supply and dies. No collateral circulation to save it.
Okay, so segmental 2.
2 lobar, then interlobar arteries, which run between the pyramids, And then where the cortex meets the medulla, they take a sharp turn to become the arcuate arteries.
They form an arch over the bases of the pyramids.
Exactly. That arcuate artery is a key landmark. From there, the interlobular arteries radiate outward into the cortex, eventually leading to the afferent arteriole and the capillary bed itself.
We have to mention accessory renal arteries.
We do. They show up in about 30% of people, and the ones supplying the inferior pole are clinically notorious.
Why is that?
Because they often cross anterior to the ureter. If they're placed just right, they can cause a kink and an obstruction.
Leading to hydronephrosis.
Exactly.
Now for the veins. They lie anterior to the arteries, and the length difference is dramatic.
It really is. The left renal vein is 3 times longer than the right, about 7.5 centimeters versus 2.5.
And this length disparity is why the left kidney is the preferred choice for a live donor.
Overwhelmingly, it just gives the transplant surgeon so much more length to work with.
And the left renal vein has a high-stakes route. It runs right over the abdominal aorta, just below the superior mesenteric artery.
Right, and that compression point is the definition of nutcracker syndrome. It also receives the left gonadal vein and the left suprarenal vein.
And those branches are clinically vital.
They are, because they provide crucial collateral drainage if the left renal vein is ever ligated.
Yep.
Conversely, the right renal vein has no significant collateral drainage, making its ligation far more dangerous for the kidney.
Okay, let's briefly touch on innervation. The renal plexus.
It originates from the coeliac and aortocarinal ganglia. But what's fascinating is the extreme specificity of the neural control of blood flow.
How so?
The axons running along the arcuate arteries primarily innervate the juxtamedullary efferent arterioles and the vasa recta. Their job is to control blood flow between the cortex and the medulla.
Which is part of the concentrating mechanism.
Exactly. But they do not directly affect the main glomerular circulation where the filtration actually happens.
That level of fine-tuning is amazing, and it leads us to the microscopic machinery where the real work happens. The nephron and the collecting duct.
Right. Filtration begins in the renal corpuscle. You have the glomerulus, which is this high-pressure tuft of capillaries supplied by the afferent arteriole.
Encased within the glomerular capsule or Bowman's capsule.
Right. And the separation point between blood and filtrate is the filtration barrier, one of the most selective barriers in the entire body.
What's it made of?
It has 3 parts. The fenestrated capillary endothelium, the glomerular basal lamina, which is the main selective filter, and these specialized epithelial cells called podocytes.
Podocytes, the ones with the little foot processes.
Yes, they're pedicels, which create filtration slits. It's an incredible structure to make sure large proteins and blood cells stay in the circulation.
And once filtered, the fluid travels through the proximal convoluted tubule, where massive resorption happens.
Right. Glucose, amino acids, then down the nephron loop of Henle to the distal convoluted tubule, and finally to the collecting duct.
And the ultimate master regulator of all this is the juxtaglomerular apparatus, the JGA.
The JGA. This is the tubular-glomerular feedback system, located right where the distal tubule brushes up against the afferent arteriole.
And it's made of 2 key cell types.
Juxtaglomerular, or JG, cells modified smooth muscle cells in the arterioles that contain renin, and the macula densa, which are specialized cells in the distal tubule that act as salt sensors.
So if the macula densa senses that the salt level or filtration rate is too low,
it signals the JG cells to immediately release renin. That kicks off the renin-angiotensin cascade, which ultimately raises systemic blood pressure and increases salt and water resorption to correct the problem.
it's an incredible feedback loop.
And that precise regulation allows the kidney's final trick, concentrating the urine. This requires 2 interconnected systems in the medulla.
Countercurrent systems.
First, the countercurrent multiplier, which actively transports salt out of the thick ascending limb to create a high osmotic gradient in the deep medullary space.
And second,
The countercurrent exchange, where the vasa recta blood vessels run parallel to the loops to conserve that high osmotic pressure. They don't wash it away.
it's basically an osmotic trap.
That's a great way to put it. The final step is controlled by ADH, which increases the water permeability of the collecting ducts. This allows water to escape into that hypertonic medullary space, concentrating the urine dramatically.
And that concentrated urine now enters the ureter.
Which is a muscular tube about 25 to 30 centimeters long that uses rhythmic peristaltic contractions to push urine toward the bladder.
And those contractions are initiated by pacemaker cells in the minor calyces.
Right, at a rate of about 6 contractions per minute.
For clinical listeners, especially anyone dealing with kidney stones, the 3 narrowest points of the ureter are just high-value knowledge.
Absolutely. The places where stones typically get stuck: First, the ureteropelvic junction, right near the kidney pelvis,
Second.
where the ureter crosses the common iliac vessels over the linea terminalis,
And the third and narrowest point of all,
is the intramural part, where the ureter passes obliquely through the bladder wall. Stones as small as 2 or 3 millimeters can get arrested there.
the pelvic relations are also highly distinct and clinically critical, especially when you think about surgical risk.
Hugely. In males, the ureter hooks underneath the ductus deferens.
But in females, this region is fraught with risk.
It is. The ureter passes immediately behind the ovary, but more importantly, as it approaches the bladder, it passes immediately inferior and posterior to the uterine artery.
This is the famous relationship, water under the bridge.
The ureter is the water, the uterine artery is the bridge. And during a hysterectomy, the ureter is extremely vulnerable to being accidentally clamped or ligated while the surgeon focuses on the artery.
It's the relationship every surgeon fears.
It is.
Finally, we can't conclude without touching on some of the fascinating congenital anomalies.
Right. What happens if development goes a little off track? The most common is the horseshoe kidney.
Where the lower poles fuse, forming an isthmus that typically gets hooked under the inferior mesenteric artery.
Exactly. And that prevents the kidney's normal ascent up the abdomen.
Then you have duplex, or double ureters, surprisingly common.
Very common. About 1 in 125 people. And this is where you have to know the Weigert-Meyer rule.
Okay, what's that?
If you have 2 ureters draining one kidney, the ureter draining the upper pole always inserts lower and more medially into the bladder than the one draining the lower pole.
Interesting. And a couple others.
Ureterosceles, a cystic dilation of the lower end of the ureter, which often gives this distinct cobra head appearance on imaging, or the very rare retrocaval ureter, where the right ureter passes behind the IVC.
Okay. To synthesize this vast territory, what are the pillars we need to remember?
I'd say structure, flow, and regulation. The kidney is retroperitoneal with that critical anterolateral orientation. Its high-flow vasculature is segmented, making obstruction dangerous, while the left renal vein is the surgical favorite due to its length and collateral support.
And regulation.
And the entire system hinges on the juxtaglomerular apparatus, maintaining that perfect selective permeability through the power of countercurrent exchange.
Absolutely. We've mapped the internal and external architecture from the massive liver all the way down to the microscopic podocytes. So here's a final thought. When you consider that the glomerular basal lamina is the principal selective filter that keeps those essential large proteins in your blood, what dynamic challenges does the kidney face daily in maintaining that microscopic filtration integrity against ever-fluctuating blood pressure? And what subtle shifts are required to prevent that critical barrier from failing?
A profound challenge for a truly complex regulator. Thank you for joining us for this essential deep dive into the kidney and ureter.
We'll see you next time.